We're pleased to introduce the LTOP system to assign periodontal prognosis by integrating simultaneously individual prognosis with Perioproject and overall prognosis with the LTO index. There is a considerable amount of uncertainty surrounding periodontal prognosis. It is assumed to be a fundamental pillar, which is necessary to assign, but we lack information to do so in a useful and reliable manner in order to enable making treatment decisions. We base the periodontal prognosis on tooth-related factors and a few patient-related factors, with some doubts about the actual impact of some of them and lacking guidelines to simultaneously interpret both groups. The accuracy of the tooth loss prediction exclusively based on tooth-related factors has been compared to the chance of occurrence of tossing a coin. Assigning hopeless prognosis to the molar on the left side, the prediction fails between 20 and 40% of the times. Assigning questionable prognosis to the remaining molars, there's a twofold failure. This does not seem to make any sense. However, far beyond the above-mentioned situation, there seems to be an entire world to be explored. We differentiate periodontal biotypes and treat tooth, gingival, and osseous defects, whose etiology and prognostic meaning remain partially unknown. On the other hand, gingival inflammation, plaque, and calculus are risk factors that once treatment has been performed, turn to be prognostic factors, and as such, they predict a better outcome. We will try to shed some light on this panorama in a practical and a useful way. Just as the individual and overall prognosis are progressively integrated, a new scenario would show itself up, making it possible to understand the prognostic meaning of both routine clinical and radiological daily practice parameters represents a specific language to communicate and understand prognosis, and justifies the actual certainty when predicting tooth loss. The available knowledge about periodontal prognosis comes from nearly 60 studies. There are around 40 on tooth loss in patients following periodontal maintenance, and 20 introducing prognostic and risk indexes. These studies were aimed at predicting tooth loss, estimate the risk of disease progression, and an essential issue, which is knowing how do patients that will experience worse outcomes look like at baseline. This is certainly valuable information. However, we acknowledge not knowing how to interpret it to make decisions. Our contribution is the result of 30 years of research aimed at developing a useful and reliable system to assign periodontal prognosis. Individual prognosis. Let's see what Perioproject consists of and how it was developed. These are examples of tooth loss in the short, medium, and long term. Tooth loss distributes evenly throughout time. So, the most reliable index to predict tooth loss would be the one analyzed during the longest time period. A 25-year study would accurately predict most part of the tooth loss rate, while a 10-year study would fail the prediction of tooth loss occurring afterwards. Thus, we believe it would be more realistic to interpret prognosis by assigning survival time, instead of predicting whether a tooth will be lost or not. This does not enable making decisions. It does enable us to suppose that we will perform an extraction without knowing when. It would be more useful and undoubtedly more reliable to predict when a tooth will be lost with a certain probability and in a certain type of patient. To serve this purpose, a tooth loss predictive model was developed. Here are some of the authors and implicated people in the project. A predictive model is based on quantitative analysis. Quantitative analysis interprets statistical figures with words subjectively. All prognostic and risk indexes have been developed this way. Quantitative analysis does not interpret, but calculates according to its own data the probability of tooth loss, with a value between 0 and 1. This can be associated with a survival time. This model is Perioproject, an algorithm constructed with 5 patient-related factors and 6 tooth-related factors, including the type of tooth. And it's linked to a complementary web for general population, offering a self-evaluation and tooth mobility test that surprises many people. How did we associate survival time with the probability of tooth loss? The baseline probability of tooth loss was calculated using teeth that were and weren't lost, introducing into the model patient-related and tooth-related factors as they were at baseline. If a tooth was lost after 15 years following periodontal maintenance, for example, then the parameters were introduced as they were 15 years ago. By dealing with the mean tooth loss probabilities alongside the actual mean survival times, survival time intervals were defined. We were able to confirm that as the probability increased, the survival time decreased, and this was shown in the tooth loss samples analyzed in our multi-center study. The model was also more accurate than us when predicting the dichotomous alternative tooth loss or not. These were the percentages in which we failed the prediction with conventional prognosis. And these were the percentages in which the model failed. Why was the model more accurate? Well, because it doesn't feel, it only calculates. However, we feel, we doubt about the treatment efficacy, for instance, and we fear failing the prediction. So, we were able to create a tool that assigns survival time. And whenever a tooth loss occurs, it matches the survival time at most of the times. 21% of teeth with assigned survival time was lost, between 82 and 90% within the assigned survival time interval. Tooth loss occurring before or afterwards was mainly explained by an unfavorable or favorable crown-to-root ratio, respectively. This was already described by the pioneers on periodontal prognosis. Our model considers these factors in non-motors. However, in motors root anatomy, this seems to be more relevant. We'd like to reiterate, though, that not all teeth with assigned survival time were lost. Some patients did not lose these teeth, while others lost the majority of them. This is very important and has to be considered when prognosticating. Almost 90% of patients do not lose their teeth or lose only a few. Only between 3 and 9% lose more teeth due to periodontitis. So it's not possible to assign prognosis based exclusively on the tooth. And therefore, the accuracy of the tooth loss prediction would depend highly on the type of patient. Overall prognosis. Let's see what the LTO index consists of and how it was developed. The studies to know how a patient that will lose more teeth is like are scarce. However, they provide us with 5 clues. These patients presented reduced initial gingival inflammation, severe periodontitis, smoking, bruxism, and less subgingival calculus. Some of these findings are controversial. However, smoking explains it. As a matter of fact, it also explains the differences of the impact of bruxism. None of these factors would be definitive, but their interactions are. We talk about bruxism, which actually is occlusal overload, agreeing with the pioneers on periodontal prognosis on that bruxism doubles the tooth loss rate. However, bruxism is not black or white, it's absolutely relative, and there are 2 circumstances that hinders identifying it and understanding its impact. First circumstance, searching for whether bruxism impacts on the periodontium or not, increasing tooth loss. It turns out, paradoxically, that teeth with signs of tooth wear are not usually lost, whereas the ones that were lost were those with fewer signs. Lower canines and premolars are rarely lost, even with extensive tooth wear. Nevertheless, these 3 molars have higher chance to be lost with much less tooth wear. Moreover, the majority of bruxism is centric, going initially unnoticed. Second circumstance. Animal experimentation could not be extrapolated to what actually happens to a bruxist patient throughout his or her life, especially if this patient is a smoker. A healthy periodontium adapts to occlusal overload, developing a kind of microtorus on the alveolar cortical plate, narrowing the periodontal space even with certain attachment loss, up to the point of claudicating, widening the periodontal space, followed by the appearance of an osseous defect. However, we usually identify already existing defects, attempting to regenerate the lesion. We have seen abundant calculus deposits in the previous radiographs. Let's talk about subgingival calculus. There are very few changes after 28 years, despite not being a very compliant patient. It wouldn't be so harmful to have so many fossils, very close to a seemingly resistant coronal cortical bone. It is surprising, however, considering the big number of deposits, the stability of the lower incisor and the gingival margins after 32 years in these circumstances, even with bruxism 25 years later, but in the absence of smoking. We'll also address how calculus deposits associate to a different response to periodontal regeneration. Relying on some of these data and searching for additional information in order to characterize at baseline patients that would experience worse long-term outcomes, the idea of developing a predictive index was born. This study did not only help to develop the LTO index, but also to understand the prognostic meaning of osseous defects, and furthermore to characterize patients according to bruxism and periodontal biotype. The first finding on the 174 patients from the study was that some parameters were associated with bruxism while others were associated with smoking. This was the protocol of the study. These 8 routine parameters were registered based on initial and final clinical and radiological data. The tooth loss and the associated type of lesion were identified, taking into account the clinical development. Nearly 500 osseous and frication defects were monitored, considering response to scaling and root planning, regeneration, and the final outcome. The whole data was analyzed in the 3 following steps, initially with these 6 variables. We have differentiated 4 groups of patients according to the presence of bruxism, smoking, and both. Number of patients in parentheses. Osseous defects doubled with bruxism, more vertical defects, and with smoking, more circumferential defects, and were 6-fold with both. Percentage of patients with more than 1 defect in parentheses. Frication lesions triplicated with smoking, not with bruxism, and were 5-fold with both. Differences in loss of more teeth were decisive. In a second step, 4 variables were incorporated into the analysis. The statistical associations are going to be described dynamically. Vertical osseous defects go with bruxism. Frication lesion with smoking. Circumferential osseous defects go between bruxism and smoking, but along with the tooth loss rate, since tooth loss usually occurs with the circumferential defect. Abfraction stay with bruxism, and gingival recession with abfractions, since abfractions implies gingival recession. And finally, the initial increased gingival inflammation and subgingival calculus stay together on the other side, far from the tooth loss rate, since these factors predict a better outcome. Here we have the 3 main patient-related prognostic factors and the associated variables
excluding periodontal manifestation of systemic diseases.
We could include more factors with presumable influence. However, due to the reduced size of the tooth loss sample, we cannot expect more from the statistical analysis, as these limitations show. If other exotic factors were included and more overall tooth loss samples were analyzed, which represent 40% of the teeth lost for reasons other than periodontal, it would be impossible to see the light. We could also fill this image with arrows indicating all the associations and interactions, but what we are actually looking for is how all of this reflects in the patient. We want to see, touch, and cure. For this purpose, and attempting to provide some physical appearance to the statistics, the periodontal biotype was incorporated to these variables, so that it was possible to distinguish thinner and wider biotypes, with or without bruxism, centric and eccentric bruxism, and according to the tooth loss rate. And we found the following.
In thinner biotypes, and even in theoretically predisposed to recession area, the gingival margin remained stable during an average of 24 years, in the absence of bruxism. This was already described in a shorter follow-up. Gingival recession occurred in a different way, associated with abfractions. The majority of bruxism was centric, with abfractions. Only 10% of bruxism was eccentric, with fewer abfractions and less gingival recession. Considering that in the presence of bruxism, teeth lacking tooth wear signs are the ones more frequently to be lost. In thinner biotypes and/or severe periodontitis, generalized gingival recession, increased mobility, and absence of abfractions predominate. The characteristics of an isolated patient are anecdotal, but several patients gathering similar characteristics conform a pattern that enables distinguishing three patterns of tooth loss associated to bruxism. A pattern of bruxism in the absence of smoking with a thicker periodontium. There's a twofold increase in tooth loss, in addition to fissures, fractures, etc. A pattern of bruxism in the presence of smoking with a thicker periodontium, abfractions, and reduced mobility. There is a fourfold increase in tooth loss. These are type 1 patient. It's common to observe hairline abfraction along the crown of the central incisors, and a pattern of centric bruxism with a thinner biotype, generalized gingival recession, absence of abfractions, and a fourfold increase in mobility. There is a fivefold increase in tooth loss rate. These are type 2 patients. The characteristic of a patient, the biotype, the habits, all help to anticipate and understand dramatic failures in implant dentistry. Attempting to systemize some of this data and providing it with clinical utilities, the LTO, or Long-Term Outcome Index, was developed with 6 categories, from 5 to 0. Depending on the presence or absence of these 5 variables, LTO index of 4 and 5 patients lose more teeth, whereas LTO of 0 to 2 patients do not usually lose teeth.
Here we can see the distribution of patients according to the LTO index categories, differentiating among patients that do not lose teeth, lose only a few, or lose more teeth. As we can see, the accuracy of the index increases as the impact of smoking and bruxism increases, associated to the 5 parameters of the index. Let's focus now on the prognostic meaning of osseous defects. These defects are detailed in this section on the Perioproject website and in the textbook edited by McGraw-Hill.
The Frication lesion predicts worse prognosis once developed in the absence of interproximal bone loss or minimal bone loss, especially in smoking patients. These lesions do not develop with isolated bruxism. The bottom images show us different lesions with a relatively intact frication area and better prognosis. With severe periodontitis exclusively, as we can observe on the left, the lesions are stable during 22 years and typical osseous defects with predictable regeneration. Frication lesion associated to interproximal bone loss, severe periodontitis, but stable with bruxism, or molars being lost progressively with smoking and severe periodontitis after around 10 to 20 years, with more or less risk, respectively. Why not registering the type of osseous defect just the way frication lesions are registered? These are not frication lesions. They are circumferential defects extending towards the frication area. The radiographic appearance of two emerging contiguous defects with a shape of a bow tie that blurs as the lesion progresses. This is a tie and a blur tie. It indicates worse prognosis with these factors. In extreme cases, there is an intrusion compromising the apex. If it occurs in the absence of smoking, the frication remains unaltered, as is the case of the remaining molars of this patient. The same occurs in uniradicular teeth. In these limiting situations, the teeth look like rotating within the alveolus. Should this happen on the previous bone loss or the so-called secondary occlusal trauma, the prognosis is definitely worse. This is the tooth loss pattern of many teeth. A completely different scenario is seen in defects that regenerate. These defects tend to be associated with bruxism, and these are the characteristics. Among others, the presence of subgingival calculus. On the contrary, in premature tooth loss and failure of regeneration, the absence of calculus predominates among other variables. Possibly now, we could recognize which patient we had just by looking at the odontogram. Comprehensive periodontal prognosis. Let's see what it consists of and how the LTOP system has been developed. The LTOP system is the method that integrates in an objective and reproducible way the data obtained with the individual and the overall prognosis. Next, we will be detailing how we did it. The individual and overall prognosis were assigned registering the survival time of the lost teeth. 100 patients were documented in this way. This table contains the results. The mean tooth loss doubled with each increasing category of the LTO index. In parallel, the percentage of tooth loss approximately doubled as the survival time interval decreased.
By identifying the percentage of tooth loss with the accuracy of the tooth loss prediction, there seems to be a huge variation. Here, we succeeded 0%, which means that we failed 100% of the prediction. And only in the opposite extreme, for the LTO of 4 and 5 categories, the accuracy of the prediction exceeds 50%, or, in other words, the chance of a coin toss. This 0 to 88% range makes no sense. However, the key word is not accuracy. Here, we're talking about quite a different issue. The calculated probability of tooth loss and the probability of occurrence of the remaining events addressed here. This represents a probabilistic language that we are going to discuss next. But first, let's address a different matter. Meteorologists do not forecast whether it will rain or not. As a dichotomous alternative, they express this event with probabilistic terms. A 12 to 22-year survival time corresponds to these tooth-related factors categories, in the absence of patient-related factors. These are the percentages of teeth that were maintained, with and without risk. This is our certainty based on a good prognosis. Intermediate survival times correspond to these tooth-related factors categories, without patient-related factors or with one or two at most. These are the percentages of teeth that were maintained, with and without risk. In this case, our certainty has to do with the efficacy of the treatment, maintaining these severely compromised teeth, despite failing the corresponding tooth loss prediction. The shortest survival times correspond to these tooth-related categories, with the majority of patient-related factors. Percentages of teeth that were maintained, with and without risk. This is our certainty based on a bad prognosis. As we can see, the majority of these teeth were lost, especially with risk. What is considered to be a bad prognosis, indicating the tooth extraction? Basically, two of these three factors. Grade 3 Frication Lesion by itself is not enough. Nevertheless, according to the literature, a high percentage of teeth in extreme situations can be maintained in the long term, even with grade 3 frication. Recording what has been exposed so far, less than 10% of the periodontal patients that we have already seen how they're like, tooth extraction would be indicated with this degree of involvement in the long term, since the majority of these teeth would be lost. Main conclusions according to the purpose of this presentation. The first conclusion expresses our certainty with individual tooth prognosis, based on the probability of maintaining or not the compromised teeth. The second conclusion expresses our certainty with overall prognosis, making it possible to identify patients that will experience worse or better long-term outcomes. The third conclusion stresses the possibility of making decisions based on the former information. Let's see an example of making decisions. After 30 years following periodontal maintenance with severe eccentric bruxism, we have a problem with this reluctant patient who refused to perform extensive restoration. As anticipated, his teeth were eventually lost, and which we finally restored. But, including a compromised molar such as this one, the patient and the expert made this decision together based on the available evidence on the probability of maintaining this molar in the long term. Finally, our two last and extremely important conclusions. We wholeheartedly thank you for your attention, hoping that this document may help you in the future. Thank you.